pleasure to be with you all. My name is Glenn Carballo with Dime Private and Commercial Bank. It's my pleasure to introduce Dr. Vasily Eliopoulos, known as Dr. Vass. He's co-founder and chief medical officer of Longevity Health, a Trinity College graduate with honors in neuroscience, and served as a Peace Corps volunteer in the Solomon Islands, teaching and collaborating with World Health Organization on malaria and fibrosis. Dr. Vass earned his medical degree from Cornell University Medical College and completed postgraduate training in general surgery. Dr. Vass is a lifetime grappler with accolades including high school state championship and recent master's titles in international Brazilian Jiu-Jitsu. Outside medicine and grappling, he enjoys rock and ice climbing and whitewater kayaking. Please welcome Dr. Vass to the stage.
Well, I just want to say I'm deeply grateful to be here. Thank you to the Greenwich Economic Forum. This is going to represent a little bit of a change of gear for you. I'm going to take this discussion from a global, cyclical level really down to a personalized, individual level. Can you hear me?
Yeah. Perfect.
Yeah, okay. So I'm here to talk about longevity. My hope and objective for this goal is to try to demystify this topic for everybody. And at the end, my hope is that you'll have a kind of a crystal clear understanding of what a true, well-executed longevity plan looks like. And to do that, I have some slides. Oh, thank you. If you could advance one more. Where's that me? There we go. So I'm going to start by telling you my story. And the pictures on the right were me in my mid to late 30s. And by all outward measures, I was really the picture of success in medicine. I'd graduated Cornell Medical School here on the Upper East Side, had gone to the top emergency medicine and general surgery program in the country, had been in academic medicine, I'd published, I'd left academic medicine, was part of a growing private practice in the Denver metro area, and I was ticking all the boxes. But one of my honors as a physician, particularly in the emergency department, is to have been with many, many people when they've been faced with their own mortality. And there's something that I've learned in those experiences is that people, when you're facing your own mortality, they speak the truth. And in those moments, they don't talk about their net worth, the deal they made or didn't make. They talk about their children, their family, their loved ones, the meaningfulness of those relationships, and how those relationships may be lacking in some way, shape, or form. And in the ER, I had my own sort of was faced with my own mortality in a roundabout way. It's the first time I coded somebody who was younger than me. And I'd coded plenty of people, trauma and misfortunes of life and accident. But this guy looked like me. He was a year younger than me. And it shook me. And I stepped back and I looked at myself and I said, I don't like what I look like in the mirror anymore. You know, as a high school, college athlete, I knew what being in shape was like. I also suffer from a familial condition, familial high cholesterol, which is common in Mediterranean descent. My cholesterol will run 350 to 450 if it's not really aggressively managed. I was doing everything all my friends at our Ivy League and elite institutions were telling me to do, and it wasn't working. And I wanted something different. And in my quest for something different, I ended up having to leave the zone of comfort in traditional medicine. And I sought the advice and guidance of people who I'm guilty of and my colleagues are guilty of calling quacks. And to my shock and surprise in that space, I found back then what I clearly thought was the future of medicine. And I was frankly shocked that I hadn't been educated in these tools, diagnostics, or modalities in the traditional setting. Now, I come from Cornell and a traditional background, and I have a great respect for what our institutions do. And what our institutions are great at and what we do better than anywhere else in the world is take care of problems. And the worse the problem, the better we are at it. But if you're relatively healthy and you want to stay healthy, we're not training our doctors in the traditional system and the tools that they need to do that. And so for me to learn to be patient number one for myself, I had to learn those modalities. And what I can say now, solidly in my 50s, that I feel better than I ever have in in my life. I take bets with my friends around, I trained jiu-jitsu, I wrestled my whole life, it's one of my passions. I would love to have a competition with my 20-year-old version of myself because I bet on me now. And so the question is, how is that possible? And what does that look like if that's something you want to sort of incorporate into your medical planning? So the question I'm going to ask you is, what's the foundation of true health? I've sort of given you the answer, but I think for most of you, and if you ask most doctors, they're going to say, well, I could eat a little better and I could exercise a little more. And that's wrong. And that's not my opinion, that's what the science and the data will show. And so it's not that diet and exercise aren't important, they are, but they're not the foundation, they're the body. And what I call, my longevity pyramid, or our longevity pyramid, is really what incorporates all of the aspects of what a true preventative, proactive health plan should have. And so what underpins diet and exercise? Next is sleep, rest, and recovery. That's both physical and mental. Underpinning that, which is actually the most potent longevity drug known to human beings, is purpose, connection, and dare I say, some component of spirituality. And there are many different roads to solve that for yourself. But then I would argue in the current day and age, the things I just mentioned, diet, exercise, rest, connection, and purpose, these are things that humans have known for thousands of years. Now, I grew up going to Greece, where my father's family's from, and people they don't even know how old they are. And it's because they've been practicing these principles in their society for generations. What we have that they don't have is the type of data, analytics, and science that those pillars haven't leveraged effectively yet in our traditional system that absolutely can be leveraged effectively to not only guide you to make sure that you're executing on these pillars properly, but making sure that you're doing it in the most time-efficient way possible. So most of us on our phones and our watches, we're collecting data that traditional medicine doesn't really pay attention to. And I would argue your lowest resting heart rate, your heart rate variability, your sleep data are probably the most fundamental metrics that you could measure. And they should be incorporated into any preventative or longevity health plan that you're engaged in. What I'm going to do is I'm going to briefly talk a little bit about each level of this pillar. And what I'll say is most people and most of the discussion in social media and the things that grabs our attention are really at the top. What can we do to optimize cellular health? What can we do to optimize physiology? What can we do to optimize cognitive function, prevent, the big bad uglies like dementia and heart disease? That's where we're sort of distracted into that realm because it's fancy, it's new. But the fundamentals, you cannot underestimate the power of those. And if you execute on those properly, when you leverage these advanced tools, biologics, and the later generation therapeutics, you'll get better results. So really briefly, working from the bottom up, community, connection. What is it about this? There's been a fair amount of study looking into this. And this originated in the faith-based community where people who attended regular faith-based gatherings lived anywhere from 6 to 7 to 8 years longer than people who didn't. And there was a lot of curiosity around, well, what is that? And the science, at least at this point, would seem to demonstrate that there's only certain things that we can control in our lives, and that's where we spend a lot of our time and attention. But when we're connected to people who we love, and we approach life from the standpoint of it's not just about me and my ego, but that we're all a part of something that's greater than ourselves, and that there's a big component of that we cannot control. And if that's a source of comfort for you, that will help extend your life. If that's a source of anxiety, and that's, I think, where in our Western societies, we have difficulty sort of coming to that place where we can gather comfort from the fact that there are things we don't control and release that control. This is where I believe the science is showing the longevity benefit, which is up to 14 years of quality life years. So there's not any other therapy known to human beings that can give you 14 years of quality life. So I just plant that seed there. Any longevity plan should incorporate some component of that. And there's no one road. There are many different roads to success there. Next, sleep, rest, and recovery. A lot of my clients, a lot of people struggle with sleep. And when you go to the doctor, you go to most providers, whether it's traditional or alternative, the first thing you get a prescription, which can be fantastic if you're jet lagged or you need it for a stopgap measure, but they are terrible long-term solutions. You go to an alternative or functional provider, they might give you, magnesium, L-theanine, they might look at your hormones, and these are all important. Your micronutrient levels absolutely should be looked at. A lot of the sleep issues lie there in the fundamentals, but I would argue that most of the sleep issues that I see that are recalcitrant and difficult to deal with actually come from the way we derive success in our society, which is we get success, I get success from sympathetic overdrive, and this comes down to our default mode network, how our brains are wired, and how we achieve success in both school and in career. And that's with sympathetic attention to detail and hard work. What we're not so good at is learning how to downshift into our parasympathetic system, activate that, and that's where we get our truly restful sleep and relaxation. What I would argue is there is no reason why anybody should be struggling with insomnia, because the cognitive behavioral therapy, the hypnosis, and the meditation techniques are there, they exist, they're coachable, they're relatively easy to implement, and you have to retrain your nervous system to activate that parasympathetic drive. It's not hard to do, you just need proper guidance in how to do it. Nutrition. Nothing is more discussed around which there is more confusion than nutrition. People don't know, should I be vegan? Is it carnivore? Is it paleo? Is it South Beach? Like what, Atkins, what do I do? And in this day and age, with the genomics and the diagnostics and the biomarkers that we can measure, there should be absolutely zero confusion around what your ideal diet is. It's very, very simple from a medical perspective to do that diagnostic workup and give you a very clear roadmap. Now, the thing that I see people struggle with is that they're worried that if they do that testing, they're going to have to eliminate a lot of things that they love. But what I would argue, and what my experience is in my medical practice, if you execute on these fundamentals, you actually can eat way more liberally than most people think. So if you have curiosity or confusion around what is an ideal diet, it's easy to solve. You need the right clinician to help you figure that out. Exercise. My problem was I thought I knew how to exercise. This is most of our problem. And you know how to exercise, but you know how to exercise the way you've been trained, usually for competitive sports. The problem is that type of training is not ideal for longevity. We create muscular patterns and fascial contraction that create wear and tear on our joints, shoulders, knees, low back. And in this day and age, with the biologic and minimally invasive therapies available, our traditional system is, I would argue, sleeping on the job, because they wait until it's too late and then you're offered replacement. Now, replacement works, but if you start proactively by exercising in a way that's, geared towards longevity to deleverage those stress points and decrease the wear and tear on your joints, and if you effectively leverage the biologics like cell therapies and peptides, you can mitigate pain late into your late years, whether your goal is running marathons at 80 or 90 or just playing on the floor with your grandkids. So I would argue that there's nothing wrong with what we're doing in traditional medicine, except that we're ignoring a huge number of diagnostic therapies that should be in between physical therapy and medication and surgery. And I would argue that stem cells, which we'll touch on briefly in a moment, is going to do to orthopedics what stenting did to cardiovascular surgery. Used to be everybody had a bypass. Now you probably don't know somebody who's had a bypass recently. It's still done, but it's rare. Stenting cannibalized CT surgery. Stem cells are going to cannibalize orthopedics, and that's not a bad thing. It's going to give people less pain, more mobility, and less surgery, and you'll still have the backup of the surgical options. So I think traditional medicine is sleeping in this space, and we'll touch specifically on this in a moment. Next, we get to cellular and neurocognitive health, and I'm just going to sort of reserve that. My goal is to speak for maybe 15-ish minutes, so I'm getting close. And then we can open it up for conversation. So if people have questions about a specific therapy or modality, we can address those then. And the reason is that we could spend all weekend on any one of these therapies. Now, like my education, like my athletic career, when I made this transition in medicine into an alternative space over a decade ago, I like to do things right. I spent a lot of time doing research in the stem cell space. I personally wrote the largest paper ever published looking at stem cells for use in the degenerative spine. I was a sub-investigator on the largest paper ever published looking at stem cells used in the degenerative knee. And on my laptop upstairs, I have the data sets for the largest paper that will ever have been published to date looking at stem cells used in the shoulder and the hip. So I spent a lot of time making sure I knew what I'm talking about. And I think, again, we could do a weekend conference on any one of these. So rather than me sort of talk about what I think is important here, I'll just leave that for the Q&A. A moment on stem cells. Nothing in medicine is more talked about and misunderstood than stem cells. Stem cells actually isn't even the right name, but if I told you, if I said stromal therapy or medicinal secreting cell therapy, nobody would know what I'm talking about. So even though the people who know what they're talking about want to use a different term, in the public space, everybody says stem cells, so that's what we're going to call them. There's a lot of misinformation around biologic therapies, the types of cell therapies, and to our credit or detriment, part of that has to do with if you go south of the border, you can say whatever you want about stem cells. If I put something on my website, it's regulated. And so there's a lot of misinformation that's circulating. If you hop on ChatGPT or Grok or one of the other bots and you ask them about stem cells, you'll get a reasonable explanation and a reasonable set of options, but it's actually, when you get down to the details, it's wrong. And that's because it's picking up on this information that is, I would say, biased. And so when you enter into this space, if you have questions, there are very good people here. I would argue 10 years ago, there was good reason to go abroad for cell therapy. Now, the best cell therapy in the world happens in this country. It's hard to find who's good. I'm happy to refer you to people in your area. This is a therapeutic that 10 years ago I was saying, in 10 years, when you go have surgery, in the recovery room, you'll get an infusion of 100 million of your own cultured stem cells because your recovery time is going to go down, your pain medication requirement is going to go down, your infection rate is going to go down. There's good data to support all of those claims. And here we are a decade later, and maybe in 5 or 10 years, cell therapy will be part of the traditional medical lexicon. At least that's my hope. And I'm happy to take any specific questions on the wide range of different types of cell therapy. I guess one last thing I'll say on stem cells. Stem cells is like saying surgery. There's lots of different types of cell therapies. There's bone marrow, there's adipose, there's allogeneic, there's culture expanded, there's A2M, there's PRP. This is a range of different therapies that we're not teaching our traditional doctors. The early adopters have to go out and learn for themselves, like I did, from other experts, and those experts exist here at Case Western and UCLA and at other places, USC, where they're sort of at the tip of the spear in this research. So you don't have, my big point is, it's a wide range of therapies. Be careful if you're getting pigeonholed. Peptides. Everybody wants to know about peptides. Here's the story on peptides. Peptides are not new. I think the GLP-1s have sort of shed light on the potential for peptides. What a peptide is, in very simple terms, you have medications, and under medications you have drugs, which tend to be inorganic molecules that bind a receptor and have a biologic action. And then you have peptides, which are actually proteins or small proteins. Now, we've used peptides in traditional medicine. Insulin's a peptide. There are antibiotics that are peptides. Of course, the GLP-1s like semaglutide, tirzepatide, these are peptides. I think this has sort of cracked open the public consciousness that there are bioactive proteins that can be used for therapeutic tools, as therapeutic tools. Some of these are FDA approved, and what that means is they can be marketed and used to treat a specific disease process. But where the question mark lies and where a lot of the interest is that there's a whole host of peptides that are not FDA approved, and this confuses a lot of people. But the example I use is vitamin C. Vitamin C is not a medication, and yet a lot of us pop it when we get sick. We know when we need increased antioxidant scavenging ability, if we take a few extra grams of vitamin C, that we believe that, and there's data to show that that might help you get over infection a little bit more quickly and minimize your risk of that severity of infection progressing. Now, you can buy vitamin C over the counter. You can go to an infusion center and get an IV infusion of low or high dose vitamin C, but you cannot market vitamin C as a treatment for any condition. That's what's required for it to be used as a medication with an FDA approval process and advertising around it. So there are many peptides like BPC-157, thymosin beta-4. We could AOD. There's all sorts of peptides that have biologic activity that appear to be beneficial for you, that can be used in a potentially therapeutic manner, that are not FDA approved. And this is where a lot of this sort of curiosity and engagement is interested in. So again, rather than bore you with a weekend-long lecture on peptides, with that, I'm going to conclude, and my hope is that you have a little bit more clarity on what the execution of a longevity plan would look like. Think back to that longevity pyramid. Don't underestimate the power of the fundamentals, and I'm here to answer any questions that I can about some of these advanced therapeutics or any other questions you might have. So thank you. Yeah.
Pyramid you showed.
Yeah.
In the pyramid you showed, what is the weighting of some of those different elements there? Is that shown in priority order there?
I would argue, okay, so data and feedback loops, I put it as a foundation because that if I were managing your health plan, how do we know if we're seeing success or not? That's in the data. And it's hard data. And there's immediate data that you can collect that are on your wearables and on our phones and watches. And then there's data that goes much deeper than that, whether it's whole body MRI, liquid cancer biopsy screening, the food sensitivity, gut microbiome. There's a whole world of diagnostics, including like biologic age testing. So year over year, how do I gauge, is my plan and our plan working? Are you aging slower than is expected? And in many cases, and this shocks a lot of people, but I think I'm speaking to an educated group here, you can actually work back your biologic age pretty aggressively if you haven't worked on that before previously. So we can make you biologically younger based on the current clocks. And there's a bunch. There's the Horvath clock and the Dunedin pace clock. So there's a number of different scientific ways to measure biologic age. We can track that over time. And so knowing are we being effective in executing for you, we can use some of these objective measures. And I would argue that the importance is represented by the width of these sort of pillars, that the lower down, the more important.
Thank you.
Yeah. Yeah, please.
Sure. So I've heard in other countries, many what's called stem cell treatment have been approved. How is the latest situation in the U.S.?
So this gets into how medicine is regulated in this country, which most doctors, I didn't understand until I got into this space. Medicine is regulated at both the federal level and really on the state level. So what I can do in Colorado is regulated by my state medical board. Now, Colorado, Utah, California have fairly progressive medical boards. They know exactly what I'm doing. We can culture expand cells, use them the way it's done abroad. Yet in other states where the medical board looks a little bit differently on these therapies, there's more severe restriction. So it leads to a lot of confusion around what's available, who can do it, and why. And that's part of the reason is it's the state medical boards regulate what the doctors and any provider in that state, whether it's a therapist or physical therapist, what they can do. Now there is FDA guidance on cell therapy. And unfortunately, the FDA has been terribly inconsistent. Some years, it's just bone marrow, and some years, you can do a fat transfer, but you can't do fat purification, and PRP is okay, and then it's not okay. So the federal regulators have done a pretty poor job of giving clinicians clarity and the state medical boards clarity. So really, the people who end up regulating this, on some level, now if I were to, put a commercial out on TV making a claim that stem cell could cure cancer, the federal regulators would come down on me because there's no proof that that's true. However, if you come to me in Colorado and you have some form of degenerative condition, we can absolutely do cell therapy for you there in a variety of different forms because of what our medical board allows us to do. And so this leads to a lot of confusion. You'll find a lot of stem cell providers in those states I listed earlier and some others. And I have clients in Illinois, Virginia, New York. The medical board takes a very different stance, and so it can be very difficult to access some of these therapies in those states. please.
How important is genetic history, and how do you weigh that?
It's yeah, great question. I remember it was the late 80s, maybe the early 90s, and I read, a multi-page spread in the New York Times about, the Genome Project and how it was going to revolutionize medicine. Medicine was going to become individualized, and we would, maybe each have different drugs. Genomics is important. It's an important part of what I would consider a full, longevity workup. But the number of genes that are actually actionable for therapy are relatively few. And we have a disconnect in the knowledge of what we understand around the genome, but it's also the epigenetics, which is the term for, well, is that gene turned on or is it turned off? And we don't have good diagnostics for that. So you could have a gene that puts you at risk for a certain disorder, but that gene could be turned off, and we don't know how to measure that yet, not accurately. And so there's a disconnect in understanding your genome and how it's actually functional in the moment and how that changes over time for you. And then there's also a disconnect in how we individualize the therapies based on your genes. So from a clinical practice, I end up looking at some genomics, and you can get your whole genome sequenced very, very cheaply now. But the problem is most of that, in my opinion, is not, actionable in a way that's meaningful. So we have to fall back on the inflammation biomarkers and the biomarkers that tell us what's actively going on in your body in this moment in time to make clinical decisions. So I think this is where I believe, my personal belief is that this is where the bots can really help us. Looking at metadata, looking at nationwide, disease patterns and genomics, and seeing how we might be able to apply the therapeutics in a different way. But the reality is, how we can make that genomics effective for therapy is pretty limited at the moment. Does that answer your question? Yeah. Yeah, please.
A lot of what this guy who's on social media, Johnson, does. He seems to be really out there and selling product every day.
So here's my opinion and clinical impression, right? Like, it makes great media to say I'm going to live to 140 and I'm doing all this stuff. The reality is, in my opinion, most of that is not really meaningfully moving the needle for your longevity. In fact, worrying about doing all that stuff is probably worse for you than the benefit that you're going to derive. For most people, my clients, what I say is, we don't need an outsized time commitment. What I need is a day for you in Colorado, so a day or two to get the real deep dive on the diagnostics. The rest can be done remotely, and all I need from you is some degree of consistency. And for some of my clients, that's an hour a day. For most of them, it's somewhere between 30 and 60 minutes, 4 or 5 times a week. And some people, it's 20 minutes, 3 times a week. As long as there's some form of consistency around the application of, the recommendations that we cull from the data that we gather on people, you can have an effective longevity plan. And so I think a lot of this talking head stuff around living forever. Now, in 20 years, what's possible? I don't know. But right now, we know there's a limit to human life that's somewhere between 110 and 120 years. And most of us are leaving, 20, 30, 40 years on the table. And those years, in the end, aren't necessarily quality of life. So the type of longevity plan that I would encourage people to think about is not living to 140. It's how do we claim some of those 30 years that we're leaving on the table, and how do we make it high quality? And that's what I believe, my clinical experience tells me that this is the way to do it. And the more time you spend on the fundamentals, the better. Yeah. Sure.
What is the stem cell you use in the cell therapy? Is like complex stem cell or fast stem cell?
I missed the end of that. So I guess what type of cell therapy we use? So we can use all types of cell therapies here. Most of what we do here in the United States is autologous. So really what it falls under is a self-transplant. So if you were to come into me and say, I've got a degenerated hip or I've got some kidney damage, is there a way cell therapy might be able to help that? It's possible for any degenerative condition to heal if you catch it at the right time. And the earlier the better, particularly in the non-musculoskeletal organs. What we tend to do is we pull cells from you, we concentrate them or purify them, and then give them back to you, and that's either in their native form, or we take those cells from you, then culture expand them, and then redeploy those cells in you, and that's most of what we do. There is the possibility of doing what we call allogenic cell therapy, and that's where you're using a cell that's not yours. Now, those are available and on the market because they're approved by the FDA for topical use, for diabetics and for aesthetics. But any therapy, once it's approved, can be used off-label by any physician for a reason that they think is reasonable, as long as that patient is consented and understands. So you can get umbilical cord, blood, stem cell products. You can get placental-derived stem cell products. Those are all produced here through donors that have been screened and through cells that have gone through our tissue processing labs here, which are highly regulated. And those can be used off-label for stem cell therapies in degenerative conditions like knees and low backs. So there is another form of cell therapy. It's a non-cell therapy, but it's a non-cell regenerative therapy. This is in the form of exosomes. This also falls into a gray area where they're available. They're supposed to be used topically and for cosmetics. But again, and I'm guilty of using them on myself because they have incredible regenerative potential. But again, this is an off-label use of a product that's supposed to be used topically. And it's important that the consent is right around that, because I might be comfortable using that with the existing data, but you might not be. And so having a provider who's willing to have a real honest conversation with you around what that data is and what the risks and potential benefits for you is crucial and important. So we can do a wide range of cell therapies. The only thing we can't do here that can be done abroad is take somebody else's cell, usually from a placental product like umbilical cord blood or amniotic tissue, a stem cell from that tissue, culture expand that, and use that in somebody else. So this is the type of therapy that's being done largely abroad. And there are arguments for and against it. The arguments for that type of therapy is that if you're 70, your cells might be a little old and tired, and therefore a placental product is a little bit more robust and younger. The problem with that is you are getting exposed to somebody else's cells. And if you're doing that in a culture expanded product, which is what most people are doing, you can end up with immunologic reactions which can be not good. So there is a time and a place for an allogenic cell therapy. However, the safest cell therapy based on the current data available is your own cell. And that intuitively makes sense. Does that cover it? Yeah.
In America, they allow to do entry?
No, so you mean culture expanded natural killer cell? Yeah, no, but you can go get that in Mexico, and elsewhere, and I'm really optimistic around the results that are there, and there are INDs at the FDA to develop those therapies to be done legally here. But again, this gets into some people in the longevity space, like Brian Johnson. Man, all they need is on a bro science page. And if you're not familiar with that term, I wasn't familiar before I entered this space, but these are the guys in the gym who are willing to inject anything in their body to, get performance enhancement. They've been using these tools for decades. And enough for some people, that's enough. Like the bro science community says this works. I'm okay with that. Can I get it? So there are people who are interested in using those types of therapies. But for culture expanded NK killer cell, infusions or treatment, you have to go outside the country currently. I'll work this way. Let's start up here and then we'll go. We've got about 8 minutes left on the timer here.
Talk about the cost of having a stem cell operation.
Yeah. So it's expensive. And generally the reason is, so when I left my traditional medical practice, you go to a cash-based system, there's a lot of things that get paid for with an insurance-based system, your rent, your clinical assistance, et cetera. When you go to a cash-based, only practice, you don't have any of that, like the rent's not covered. So expense is high. I would argue that as we see adoption of, like right now in the orthopedic practices in Colorado, you have early adopters who are starting to do PRP and stem cell therapy. That's going to bring the cost way down. But you're looking at that, to have somebody good do it right, you're looking at thousands of dollars for any therapy. And then depending on what you want to do, it could be way higher than that. So it can be cost prohibitive. Yeah.
We're sitting in a room full of investors, and so if we live to be 120, I think we need a different pension plan to focus on the future, or
I defer that to you. You are the experts there. I think that that's not going to be, a plateau moment that suddenly people are living to 120. I think it's going to be more gradual than that. And the reality is probably moving the average life expectancy to 80 to maybe 90, that would be a huge monumental thing for it's doable, but I wouldn't expect that anytime soon, in my opinion. Yes.
So in Japan, the stem cell treatment is actually recognized by the government decades ago,
Yeah.
and my family also practice it. It's quite good for those audience who is curious about it. They only allow one's own cell to be cultured as stem cell.
Yeah.
But you're quite right. In other places, other regions, placental cells can be used as stem cell.
Yes.
I just wanted to ask that if you could elaborate and speak the differences about these two, other than your earlier note on it, and also are there any research data that following the people who uses own cell versus other people's cell, the impacting healing effect, and then possibly maybe any other side effects?
Yeah.
Thank you.
So great question. So the data, and part of the problem, in my opinion, on the reason for traditional medicine being slow to adopt these biologic therapies is that there are a lot of claims made, and a lot of these clinics that have been very successful in Panama and elsewhere have not collected and published long-term outcome data on their patients. And so the data that we collect, and really it's not just me, these papers that I've said I've had a hand in publishing, we're pooling data from multiple clinics. We've had resistance. I've applied for funding. The research space sees a small private clinic and says you don't have the support of a large research department like at the universities. We don't think you can pull this off. And I understand their point, but there's a lack of funding for this type of research, and that research for the longitudinal data and the outcomes data that we need from the allogeneic cell therapies is not being done by these clinics outside the U.S. So the most robust data we have is on using your own cells, whether it's a same-day non-cultured product or your own cultured cell product. And there are certain specific scenarios where it might be beneficial for you to use somebody else's cell. But in general, I would say you want to make sure you've exhausted all the other options, because you are going to be exposed to somebody else's genetics, and your immune system is going to be exposed to those cells. And usually those cell therapies are done with massive culture expansion, meaning you're getting exposed to hundreds of millions of those cells at a time. And when it goes bad, it can go really bad, because I've seen some of those cases. Now, it's rare in my experience, but it can happen. And so that's why my general recommendation to you would be the data supports using your own cell before using somebody else's. And there are scenarios where somebody else's cell might be the right thing for you. But this is where you really need a clinician who is experienced in making those decisions to make that assessment and decision. Yeah.
How much nutrition training do doctors get in medical school?
Yeah.
And I'm going to guess at your answer and ask, if you could design a nutrition curriculum, what would be some of the underlying philosophies that you would want up-and-coming medical students to know?
Yeah, great. I love it. I love Cornell. I'm appreciative to my mentors there, and I had about 2 days of nutrition training in medical school, literally. But here's the thing. I think the one source, if you want if there's a book or a person, Valter Longo, The Longevity Diet, that is the single best source for nutrition information that I can recommend. I've been recommending it for years. He's an Italian PhD scientist. He's out of USC. He's done a lot of the foundational research. He's been involved with the Harvard Health Study, the Framingham Study. He knows the nutrition data in and out. If most doctors just read that book, and then, in my practice, I give nutrition advice. And really, I think the one other thing I'd say, other than reading The Longevity Diet, incorporate fasting into your life twice a year. If we as a nation incorporated a simple 3-day fast twice a year, we would completely transform the general health of our population. So that is safe for the vast majority of people to do. And I don't think doctors need to become experts in nutrition. If they read the longevity diet or had principles, I rely on a professional nutritionist to work with my patients. Now, I gather the data, I interpret it with them, and then the reality is for success on a nutrition plan, people need almost daily coaching at the outset. Because if you suddenly have to purchase different kinds of things, I'd say more than half, 90% of success in nutrition is having the healthy things available. So you can go grab it. And myself included. Am I grabbing a piece of fruit or am I grabbing a bag of chips that my wife got for my kids? Making sure you have the healthy things available for you is, the biggest part of success. So that would be, the person I would point to design the nutrition program would be Walter Longo. Way better, way more qualified than me. And his book is fantastic. You should read it if you haven't. Yes?
So what do you think about all of these?
I think they have a place. So the question is, what do I think about the obesity drugs? And I'm assuming you mean sort of the GLP-1s, the GIP peptides. Here's what I think. I think, this pyramid's a great example. You can employ whatever drug or therapeutic you want at the top of this pyramid. And if you're building it on a rotten foundation, your results are going to be kind of rotten. So you cannot underestimate the power of fundamentals. These are highly effective tools. They have benefits that go beyond obesity treatment. The early data on long-term cognitive health and long-term cardiovascular health looks really, really good. And so using low-dose GLP-1s and GIPs at super low microdoses for people who are developing insulin resistance usually in their 40s and 50s is a fantastic way to use them effectively. But anytime you're relying on a crutch to drop large amounts of weight without addressing the foundations of this pyramid, you're going to end up yo-yoing and rebounding. And this is where you're seeing people who are developing really malnutrition because they're not eating enough, because they're highly effective appetite suppressants and osteoporosis in women. So there's no one tool that's perfect. I think they're an effective tool when used appropriately. Yeah. And then. Oh, yeah, absolutely. Can cause hypoglycemia. Yeah, sorry. Yeah, meaning in the peptide space. So. Yeah, so I think the point here, and the question is really like, how do we look at supplements and these sort of things in the gray, like the peptides in the gray area? And here's the thing. No medication is side effect free. No supplement is side effect free. You can take too much magnesium and develop a heart dysrhythmia. So no matter what you put in your mouth, there needs to be thought around the reason, the therapeutic efficacy, and the dose. And that's true whether it's vitamin C, magnesium, or a GLP-1 or an antibiotic. Yes, sir.
Last question.
Yeah.
6 of the 7 pillars appear to be non-physical. I'm curious if you can comment a bit on mental health, given that the data and feedback loops that we often see are social media related, and many countries are banning aspects of that.
I love it. So yeah, you're right. Maybe that's a point I should include that. I personally feel that mental health is rooted in the community connection purpose pillar. And that doesn't mean that there isn't space for therapeutics, and whether that's mental health intervention on a person-to-person therapy type of treatment, or whether that's a pharmacologic treatment. But I would argue that most or much of the mental health crisis that we see and we struggle with, in not just this country but in all countries, has to do with the lack of the community connection and purpose and the foundations of our families. And that's not to say that there aren't hard organic psychiatric conditions. There are, and that those definitely required a different type of treatment. But most of the anxiety, most of the depression, most of the things that a lot of people struggle with, not only do we have good solutions for, and this is where I might add, I'll drop the psychedelic, so the appropriate use of low-dose psychedelics is revolutionary if you're up to date. Now, those are drugs and they're side effects and they have to be used very carefully, but there are many, many tools in our toolkit that go beyond what most people are offered, and the purpose connection, I think, is the most fundamental component there. And I think with that, we're done. So I really appreciate your time. Thank you.